So fluid boluses, as you've heard from Shailesh, are very common. Most of us give them because we take their validity and usefulness for granted. They are the most common initial response to hypotension. And yet, despite the fact that we do it so often, there is limited understanding of why we do it, how much we give, and what are the physiological events that follow. Even though we give fluid to patients, it is often in the clinical situation unclear just exactly what it is that we're trying to achieve. Are we trying to lower the heart rate, increase the cardiac output, increase the CVP, increase the urinary output, decrease the vasopressor use, change the peripheral signs that we look at, all of the above, some of the above? This is never stated, and so the outcome that you say you're going to achieve changes depending on what it is that's actually happened, and you retroactively define whether you've been successful or not. But of course, as you well know, that's clinical practice. So you've got to ask yourself some questions. Why is it better, as Craig was pointing out, why is it better to have a liter of fluid in the body and a CVP of 11 instead of 9? And I certainly can't answer that. Why is it better to have a liter of fluid in the body and a noradrenaline it's gone from being 10 instead of 13 or 14? Well, why is that better? I don't know. Why is it better to have a liter of fluid in you and for a period of time, by the way, of uncertain duration, have a cardiac index of 3.3 instead of cardiac index of 3? We don't actually have any answers. I certainly don't have any answers to those questions. If you're able, as I'm lucky to do, to go to the animal laboratory, you can look at the effects of fluid loading on things that we cannot see in the clinic. For example, if you take a sheep, usually about 40 kilograms, and you give that sheep a big bolus, in this particular case, 1,500 mils in 15 minutes, which would be the equivalent of me receiving 3 liters of fluid in 15 minutes. As you can see up on the screen, this is what happens. The control sheep receiving nothing, just observation, has just random fluctuations in the renal oxygen delivery, if that is the target. And you can see that if you give normal saline or gelofusine, your oxygen delivery actually decreases. And the reason it does is that you've just diluted the hemoglobin, as you've seen from Shailesh data, and of course this applies to human beings, inevitably, and the renal blood flow has not changed at all. The renal blood flow has not changed at all. And this is data from animals. This is more data in detail from animals, giving normal saline or hypertonic saline. You can see that giving large amounts of fluid has no effect on renal blood flow. So if that was one of the logical explanations that you would tell the medical students or your colleagues you gave fluid for, let me tell you, this is not going to happen. Now, some of you that are old like me might remember the good old days when there was a desire to fill in order to augment cardiac output. These were the Shoemaker, Rakow days where you actually gave filling and filling and filling and filling until you got that magical CVP and the magical cardiac index of 3.5 or 4. Those were the 70s and the 80s. And if you did that, where you gave albumin or you gave saline, you ended up with wonderful fluid balances of 10 liters positive. And of course, this was nicely published in the 80s, and if you did that, 87% of your patients receiving saline fluid resuscitation ended up in pulmonary edema, and a little bit less with colloids. And of course, in these papers, very nicely, absolutely no effect on urinary output. Thankfully, we have abandoned this approach to fluid resuscitation, but I would venture to say hundreds, maybe thousands of people were hurt by that belief system. So, a little bit like Shailesh, we wanted to understand what the hell it is that we do with fluid resuscitation in our institution. I was lucky to have Julian Bion's daughter visiting us. She's a medical student in the UK, and Cauê Mate from Brazil, and we did a prospective observational study of fluid bolus therapy in a very similar way to Shailesh. And this is the sort of things that we had in our patients at baseline: a mean blood pressure of 68, a urinary output of 40, a hemoglobin of 9, and this is the sort of population that would get fluid boluses, again, for reasons that are unstated, unclear, unpredictable, clinician-based, random, variable, and totally incomprehensible. And the most common trigger, as you've heard, is hypotension or increasing vasopressor requirements. Oliguria, as you will see there, is a common trigger. A low filling pressures also, for perhaps bizarre reasons, also a trigger. And there's all sorts of other stuff, whatever the hell that is, that would trigger as the primary trigger. And if you look as a secondary trigger, so something can be a primary trigger, and there could be other additional triggers. You can see, again, oliguria and low filling pressure having primacy there. And again, whether they are logical, demonstrably necessary or not remains open to question. This is what happens in patients who receive a fluid bolus. And you can look at the differences in blood pressure, which are in the cardiac index. So this is the cardiac index in the patients in whom cardiac index was being measured. And you can see that at about 2 hours after fluid bolus, the cardiac index was significantly greater than before the administration of the fluid bolus, but the difference was 273 mils per meter square per minute. And then you've got to ask yourself, in patients who have an average cardiac index of about 3 or thereabouts, whether this constitutes either a necessary or a beneficial intervention. This is the blood pressure plot, and you can see there it is statistically significant, just like in Shailesh data, but the magnitude of the average effect is essentially the same. We are no different. And again, 2.3 millimeters of mercury mean increase. And this is the diastolic, the mean arterial pressure on the systolic. The average change is 2 millimeters of mercury. This is the urinary output, and you can see there is a huge scatter of values of urinary output in people who have been given fluid resuscitation by clinicians. And you can see, I love this data, the baseline urinary output average was 40 mils an hour. At 1 hour it's 41, at 2 hours it's 40, and at 4 hours it's 45. So if you're giving fluid resuscitation, as our doctors do about 20% of the time, because there is oliguria, well, that surely fulfills the criteria for physiological masturbation. So there is a clear hemodilution effect. All right, there's a clear hemodilution effect, and you've seen that with Shailesh data. It's here with us. So if there is a theoretical construct in your mind that by increasing the cardiac index, you will increase the calculated oxygen delivery, let me tell you that by inducing hemodilution, the construct is undone, and the change in hemoglobin concentration is proportionally similar to the slight increase in cardiac index, and your calculated oxygen delivery hasn't changed at all. So we have a magical instrument, a totem that sits in the middle of the ICU that is touched by all the clinicians almost all the time. In 2 months, it was touched 405 times. And it's a taboo to raise the question of whether we should touch the totem for its magical healing powers. So why do we do it? Given the absence of data, given the absence of clinical outcome benefits, given the uncertain physiological benefits, given the limited physiological efficacy, why is it that we're triggered into doing this? Well, I'm a fan of the Millennium Trilogy. Some of you might have seen the movies. Let's just go and talk about some of the things that might be triggering this kind of thing. I think what happens is people at the clinical coalface see a specific phenotype, or maybe they don't see it, they perceive a particular phenotype. Patient is unwell or hypotensive, or the lactate might be up, or the urinary output might be down, or the heart rate might be up, or whatever that might be. Then they make an inference. They make an inference because they can't measure it, that there is inadequate organ blood flow. That inference is necessary because clinically we have no way of measuring organ blood flow in the clinical situation. Then after they've made that inference, then they make a second inference, right? That there must be an inadequate cardiac output that is responsible for what they see at a phenotype level. And that must be happening because there is reduced preload. And once you've made all those inferences, for which you actually have no data, then it all becomes logical, because then you need to restore cardiac output in order to restore organ perfusion, because that must be happening. But is there any evidence that this happens? If the problem was increasing filling pressures and increasing cardiac output, would vasopressors and inotropes do it better? And perhaps even more relevant, why do we want to increase the flow of toxic, septic, cytokine-filled blood to organs that may not want it, that may be protecting themselves from this highly toxic sewerage of inflammatory stuff that's circulating in the body? What if the organs are actually malfunctioning due to inflammatory injury instead of inadequate flow? What if hypotension in the setting of sepsis and intra-organ shunting is a way in which the body protects itself and has evolved to protect itself over millions of years? We don't actually know in any case that giving fluid bolus resuscitation increases organ blood flow. And if it does, we don't know how much and for how long. We don't even know that it increases cardiac output, because now no randomized controlled trials. And we don't know how much it would and for how long. And we obviously don't know if the trade-off of the price we might be paying to achieve those goals is worth it. We don't have data on organ blood flow, we don't have data on the effects, and we don't know if the gain is worth the price. Now, I know this has been a frontal attack. I don't want you, however, to go out here and consider this a license to kill. Madness is not licensed by critique of routine behavior. A critique of society does not mean that schizophrenia is allowed. But a critique of society is nonetheless important for society to improve. A critique of what we do in critical care does not mean that patient neglect is allowed, but it is nonetheless important to improvement. So let me conclude by saying the fluids can have a high physiological price. They do not correct vasodilatation. They do not lead to a sustained increase in renal blood flow. They do not increase reliably perfusion pressure in human beings and in mammals. If you're given a vasopressor, you can stop it. If you're given fluids, you can't take it back. And for my area of interest, if fluids protected the kidney from acute kidney injury, the disease wouldn't exist, because all you have to do is give fluids. Patently, that is not true. The truth is that at a much deeper level, we actually don't know what we're doing and why we're doing it. Thank you very much.
So I invite people to come to the microphone, but while you're doing that, and I see Bob Wright coming down.
Oh, that's great.
But I'm going to...
Bob is upset with me because I showed everybody that he's in atrial fibrillation, that's why.
Look, there is an Achilles heel to what you've been talking about, and that is the fluids you've been using. Almost certainly normal saline, which no one in the right mind would use. And a lot of the colloids are given in normal saline as well. But the Achilles heel is that as you raise the serum chloride, you get renal vasoconstriction. And therefore, this could colour all your measurements of urinary output, because normal saline does not help the kidney to...
So, I'm sure everybody's familiar. There is a whole body of data about the effect of chloride on the macula densa and probablotubular glomerular feedback and renal perfusion in man, in volunteers, and in animals. However, today, I know you will correct me, but about 50% of fluid resuscitation, fluid bolus, is saline in Australia. And I can tell you in the process trial of early goal-directed therapy in the United States, it's about 85, 90% of resuscitation. So, Bob, I agree with you. All the more. We are in a variety of intellectual spaces which are open to challenge. And the composition of the fluid is absolutely open to challenge. But right now, today, in the world, saline is the king. A false king, an evil king, a problematic king, but the king it is.
Can I also perhaps expand a little bit on a topic you raised, where fluids may not be the answer, because particularly in septic situations, you've got the leaky capillaries where the fluid leaks out, and you hinted to the use of catecholamines. And I think that's an area that really needs exploration.
Absolutely, yeah. That'll be the next meeting. We'll attack the catecholamines.
Because the greatest example of this, of leaky capillaries, is anaphylaxis. And we know by giving catecholamines we can stop this leak. And, you know, your big swollen tongue, your lips and everything can go down before your eyes.
Yeah.
So we should really be thinking of catecholamines in the early stage of sepsis rather than drowning people in fluids.
Yeah, that's absolutely right. And so, Bob, that's why this morning I was doing that workshop, because if you know the cardiac output, then you have a logic to give catecholamines in the emergency department very early in those people in whom the cardiac output is either normal or high. So we need a way to do that quickly. Completely agree. Yeah.
Jeff Shaw from Christchurch. I think the problem really is us, isn't it? It's the way we think about resuscitation. And there's a guy called Dylan Evans who's written a whole book on risk intelligence. If you do a Google search of risk intelligence, you find that it doesn't turn up any hits in the medical literature until you go right back to 1983. So what risk intelligence is actually the ability to understand, to know how good your guesses are. And Shalisha's presentation showed that our risk intelligence is very, very low. And it was low in the paper published about doctors' ability to predict someone who has pneumonia from symptoms. So I think the next bit of research has to focus on us, you know, the way we think. How good is our risk intelligence? It's not just fluid boluses, but it may be, you know, how we give out catecholamines or how we change the ventilator settings, for example. So I think there's a whole area of investigation that needs to happen.
Yeah, I think it's very important and it's very difficult. Human behavior is diabolical, so it's very difficult to investigate. Yeah, but I think it's a fair comment, yeah.
Rinaldo, I was sitting up the back debating whether to ask you a question. I've come all the way down the front because...
after all the cycling this morning.
Yeah,
very
that's
good.
Right, yeah, and the swimming and that. Look, I'm asking on behalf of all the nurses and junior doctors that are in the audience at the moment, because you know, we're going to hear it from a number of speakers, but you're up on the stage at the moment. You are obviously across all this literature, you're doing the research, but this afternoon you're on in the ICU and you've got a patient before you and the nurse calls you and says, Rinaldo, the patient's oliguric, the blood pressure's down a little bit, the noradrenaline's just gone up, the CVP is about 8, 7,
pick a number,
whatever.
Yeah.
What are you going to do?
Well, it depends on whether it's late at night or in the morning. If it's late at night...
Exactly.
If it's late at night, it's absolutely a fluid bolus, so that it will keep the person occupied. And what I would prefer to do it over a couple of hours, so it keeps people occupied. And then that happens, and then there is an after, like a T shift and so on, and then probably about 4 hours go by. And people look at the urinary output and so on, and that allows that to... And so what you would do is advocate a fluid bolus very slowly and relatively small in amount, so it doesn't really do that much that's particularly harmful, but allows you to sleep. So that would be... During the day, then you would have a more critical assessment of what's going on, and would say, look, maybe we should know the cardiac output, maybe we don't, is the patient well perfused and everything else, and then you make judgments, and it will be an intricate web of judgment making, which Jeff was alluding to, which is the difficulty of all of that integrated human behavior that takes into account judgments about risk and benefit at different levels. The blood pressure, the catecholamines, the patient, the chest x-ray, whether they got pneumonia or not, whether they're leaky, like all that kind of stuff, all of which are spectacularly imperfect and have no particular demonstration of value, veracity, reproducibility, but nonetheless constitute the craft. And I wish I had a better answer, but I don't.
And my second question is, when it is during the day and you're on and you don't need to go back to the office to finish
to write my papers, damn it? Yeah. All right.
Do you give your fluid bolus by asking the nurse, yep, give X amount over the next period of time, or you give some instruction to the registrar?
Yeah.
Or do you have one of those tubings where you can actually squeeze it yourself and you actually squeeze the fluid in and give a dynamic challenge to the circulation and see right there and then what happens to the heart rate, blood pressure, cardiac output? Which way do you do it?
So the answer is, again, it's very variable. I mean, you've got different pitch situations. You've got somebody who's, very hypotensive, where you're actually reaching for maybe a vasopressor drug and you want to restore a blood pressure of at least, sort of 70 systolic. There are all sorts of different situations. So my answer is it would be colored by the clinical situation. And again, it's non-reproducible, subjective, biased, judgment-based, imponderable, potentially irrational, driven by heuristic bias, potentially wrong, potentially harmful, and that's all that I can do. It's intellectually demeaning and sad, but that's all that I can offer. And so my task is to stimulate people to start asking some of those questions so that we can deconstruct elements of it a little bit to understand a bit more what we do and whether it's worth doing. That's all.
Thanks.
I think
I think we do.
Okay,
thanks very much, Rinaldo.